We we use trauma deaths as audit filter for quality improvement in medicine in general, and trauma is no different. Some folks in the room know the story, but I'll tell you for the younger folks how this trauma system started. But if you look at what was going on in this county in 1979, 1980, between 79 and 82, really, when the study was done, people were going to 18 ERs all over the county. They were open for business. Trauma patients were going there. And the quality was poor. And a group of trauma surgeons felt that we were not providing trauma care, adequate trauma care to San Diego County residents. And they decided to do a study and look at the overall mortality and how many of those deaths could have been prevented if people got adequate care. So when they look at all trauma deaths in the year 1979, they identified that 11.4% of the deaths could be prevented. So more than 10% of people that died should have not died if they received adequate care in a trauma center. There were no trauma centers. and they went to the media, they made a big stink out of this, and this created a little bit of friction with the county board of supervisors, who called for a meeting with this group of surgeons and community leaders, and finally agreed to support the creation of a trauma system in San Diego. So that's how it started. Started with a piece of research. But what they said is, okay, we are going to allow you to create a system, and we are going to support the system, and we will provide some resources for the system, but you're going to have to repeat the study 2 years after the creation of the system and show that things got better, because you're telling us that this is the only way to get it better. Is Pat here? I don't know if he's videotaping or not. No, that's okay. I told him not to videotape the first part. So imagine, what is it that we can do in medicine that changes outcomes dramatically in such a short period of time? That was a pretty significant challenge for the system. But these guys were very motivated. They were very smart. They created a good network of hospitals. And to everybody's surprise, the system started in 1984, as you all know. And in 1986, the study was repeated, and preventable deaths dropped from 11.4% to about 2%, considering preventable and potentially preventable. And that was shocking to everybody. But it was based on the commitment of trauma hospitals to look at quality improvement in a very different way. Nobody used to talk about quality control in medicine in 1984. Every hospital had a different way of doing things, and these guys sat together and standardized a bunch of protocols and a bunch of processes, and the system became what the system became. Interestingly enough, over the years, we've always kept an eye on this type of data, because for us, there are so many different ways to measure quality, but ultimately we are here to save lives. And mortality is always the target, right? If you do everything right and decrease this, decrease that, decrease pneumonia, this and that, but people die, at the end of the day, people die. So that's the importance of trauma deaths, because in 1984 was important to put this wonderful system together, but we've always kept an eye on our performance and use it as a performance indicator. So we've looked at this in many, many different ways in the last 32 years that the system has been in place. This is work that Jose Acosta did when he was a fellow here in 1996. And he looked at 900 deaths from 85 to 95. So basically the first 10 years of the system's existence. And you all know, and you've all heard about this trimodal distribution of deaths in trauma, right? 50% of people that die, we don't even see them because they die at the scene or during transport. Then 30% die in the first hour. That's why we call it the golden hour. And then 20% die a week later in the ICU from multiple organ failure, sepsis, and everything else. It turns out that when you get really good at what you do early on in the trauma bay, since you can't affect the deaths in the street, but you learn how to resuscitate people, you are aggressive, you have a team approach, and we have nurses like you and the resources that we have. When we looked at this, we realized that we didn't have the second peak of mortality or the third peak of mortality a week later. Most people that die in our trauma center, they die very, very early on. Most deaths are within the first 6 hours. And if you look, what happens between 6 hours and 24 hours, that line is flat. So people still die a little bit, at 12, at 18, and etc. But very few people will die after the first day. So when you look at mortality rate at the beginning and mortality rate a week later, we don't see that second peak. And most people that die, they die because of devastating head injuries or exsanguinating hemorrhage. So those are the two things that we need to really focus on and improve all the time, because we need to stop the bleeding and be able to get people with severe TBI through the first day or so. This is data now from 85 to 2006 that I looked at. And at that time in 2006, if you look at all trauma centers in the country, the benchmark for mortality, considering all comers, was 7%. So if you look at any trauma center in the country, 1,000 patients or 10,000 patients, doesn't matter, 7% die. It turns out that ours was 5.5%. So we've always been below the national average. And if you look at the distribution of deaths, we improved over time. You see, when the system started in 85, it peaked in 89. There was some stuff going on in terms of violence here in the county and more gunshot wounds and stab wounds. But all in all, when you look at all deaths in aggregate, the mortality rate has dropped dramatically over time, which speaks for the ability that we have to resuscitate them. And I credit this to three things primarily. One, we have a freestanding trauma center. All the resources of that room are to take care of trauma patients. We don't compete for resources like if you were in the emergency department with a myocardial infarction here, a stroke here, a GI bleed there. The nurses are responsible for this in great part because it's a group of specialized trained nurses that do this. And third, because we've been very, very aggressive embracing new protocols as they come along. So those three factors, I think, make a difference. And you know the results of our OR resuscitation protocols that obviously play a major role here. During that time period, I decided to look at preventable deaths again, do the same that the guys did in 1984. And it turns out what you see in orange is preventable death. So it's stuff that happened that should not happen at all. Blue are potentially preventable deaths. What are they? They are deaths that they are probably not, there is no clear cut between them and preventable death, but we identified errors or delays in the way we provided care that if those could be avoided, maybe the patients would have a different outcome. And then the rest is non-preventable, people that die because of the severity of their injuries. And you can see it is a very, very small number of patients considering the annual volume of the trauma center. But we were definitely below the 10% or 15% that you read in the literature. So another way to look at this is that when you look at all patients during that time period, almost 29,000 patients, ISS is their injury severity score. So the higher the number, the more likely patient will die. And PS is probability of survival. So there are equations, there are things that we can calculate to estimate what people's probability of survival was. So in all our patients' probability of survival was 9.4%, which indicates that 6% should die and only 5.5 did. So we did better than the estimate of those scores. But what amazes me is this number. Only 7 cases of preventable death in 28,000 patients. And this is not us saying it. This is the way we do quality improvement in the county. This is the other trauma centers saying that those deaths were preventable, because we don't adjudicate on our own deaths out at the trauma systems level. We adjudicate internally, but then I have to submit my data to the other centers to verify if I'm not lying. So in this system, there is no way you can hide the dirt under the rug and say, oh, I'm the best, because somebody will catch you. So, but this number is extremely low, potentially preventable 34, and you see the number of non-preventable deaths there. So what were those cases? Can we learn something about them? You know, what I'm showing this to you to understand the pattern. When we make a mistake, we make a big mistake. So we gotta be very attentive and very focused so we don't make those mistakes. Most of those deaths were caused by an error in management or an error in judgment. Failure to recognize the need for thoracotomy. This is a case that the patient was bleeding in the chest, got a chest tube, got a second chest tube, bled and bled and bled, and people delayed the thoracotomy. The thoracotomy should be done hours earlier. So, big problem. The second one concerns me because there are some patients that give us a false sense of security. They seem stable, but they're not. So our inability to recognize subtle signs of shock. When people are a little cold and not perfusing well, and the base deficit is not moving in the right direction, and people say, oh, he's drunk, and this may be alcohol, and this and that. That's when we make mistakes. Inability to recognize peritonitis in a quadriplegic patient. This is a case, some of you may remember, a young 20-some-year-old kid that was in an ATV crash. This is about 10 years ago. Stayed in the unit for a prolonged period of time, then moved to the IMU on the 5th floor. And I was the attending on the service. I came to make rounds in the morning and saw the patient. He was doing fine. He was not tachycardic or anything. And so we carry on with the other stuff during the day. And he had a perforated duodenal ulcer sometime in that morning. And because he was a quadriplegic, he had no abdominal pain. And when he decompensated, became hypotensive tachycardic, was several hours after the ulcer perforated when he developed peritonitis. So we felt that we didn't recognize peritonitis, and he could very well have peritonitis when I saw him, but he had no abdominal pain. So increasing our awareness that those complications in quadriplegic patients exist may prevent some of this. And airway issues, we know that, right? The index case in this particular study was a facial fracture patient with complex mandible fracture, goes to the operating room, gets fixed, it's wire shut, extubated at the end of the case, and gets in trouble in the PACU or when the patient goes to the IMU. Those disasters can happen, right? So these are the issues. And then there were a couple cases of delays. One, delay to go to the operating room for a laparotomy that bled more than he should, and a delay to start blood transfusion. And this is in a time that blood transfusion was not very common like we do it today. So fast forward several years, Vishal and I and others look at the same issue again. And we were very interested in this issue of, well, if we don't have a third peak of mortality and people die early on from head injury or bleeding, what's the intersection between those two injuries, and what can we learn if we analyze the data on those deaths? So this goes from 99 to December 05, and you can see again the same graph that I showed before. Very few people die after 24 hours. Most people die in the 1 to 3, 1 to 6. So this is probably 85–90% of the deaths. So our focus should be still in the stuff that we do there. I don't want you to read all this, but this shows that most deaths occur early on, and these are people that have very, very low GCS, as you can see, 3, 5.2, 6.9, and very high injury severity score. So these are severely injured patients, obviously died for a reason. And then this lists the injuries itself, so cerebral contusion, lacerations, subdurals. It's all TBI stuff, but interestingly enough, you have in the 0 to 1 and a little bit in the 1 to 3 injuries that bleed too. So bleeding and TBI early on. As you move along time, you don't have many of those injuries that are going to bleed, but the numbers of TBI deaths still elevated. So really very, very important that we, trauma surgeons but non-neurosurgeons, know how to take care of these folks in the ICU. Let me skip this one and show this one, which is the most interesting one. So those lines, this one is hemorrhage, that one is TBI. You see that if you have a TBI, and this is obviously your clinical experience as well, people don't die in the first hour, but they die when they go to the ICU, and a few hours later they herniate. So mortality goes up from TBI over time, but it goes down from hemorrhage. And they cross, those lines cross around the 3-hour mark. So most people, again, and they split at the 6-hour mark. So most people are going to die within 6 hours. So we thought that the opportunity to do something about it was really not the golden hours, but the golden 6 hours. That's why in the title of this paper it says the golden 6 hours, because it's really those critical hours that we have to be extremely aggressive in the trauma bay and in the ICU or in the operating room, or RISAs, if you're going to make a difference. This is us compared to the rest of the country. This is a trauma quality improvement program. We have a way in trauma to benchmark ourselves, to compare ourselves against others, because there are benchmarks for trauma. So these are trauma centers that submit data to the American College of Surgeons Committee on Trauma, and they rank hospitals based on your quality performance. So this is risk-adjusted mortality of a bunch of trauma centers, and where you want to be is on that side of the graph below the line. So the closer to the left and below the line you are, the better you are. So in this particular quality audit filter, risk-adjusted mortality, in this report we were number 6 in the country. Pretty remarkable, pretty good performance. And this is shock patients, which tells us that we are doing the right thing. And then just recently we completed the same study from 2000 to 2014. So looking at the last 15 years, because this is when I became the director. I wanna know if I made things worse or better, and how we were doing in terms of preventability. The group number of faculty increased. It's a lot easier to control what you do when we were 3 faculty. And you guys remember when it was Winchell, Hoyt, and myself taking 7 calls a month, and well, now we're a larger group. There's younger people, and the volume is higher. So what's the impact of those things? So basically, we looked this time at 35,000 patients, and the probability of mortality was 4.2%. We actually had 2.5% mortality. We went from 5.5% in 2005 to 2.5% in 2014. So during the last 15 years, our mortality continued to drop, which is good. We have 70% autopsy rate, which helps us to understand why some people died. And when we look at preventable deaths, in 35,000 patients with 874 deaths, 6 preventable deaths. So remember, the system had 12% before the system, went to 2%, 1%, and UCSD is 0.7%. You don't find this data in the country. This is the best preventable death rate probably in the world. Potentially preventable 1.7, and obviously non-preventable the rest. And this is just to show you, if you look ISS, very severely injured population. Interesting enough, the preventable death rate is preventable deaths occur in patients that are less injured than non-preventable deaths, and their GCS is much higher. So this is really human error, not related to injury severity. And here is preventable deaths in people that have severe injuries. AIS greater than 4 is almost a devastating injury. So obviously, if you have, we had 6 preventable deaths, but only 1 had a devastating injury in the head, which tells us that the other 5 didn't die of a significant head injury, but died of a human error. So it's important to see it. And that is how and when the deaths occur. So you can see most deaths occur between day 0 and 5, most actually in the first couple days. But then there's that plateau after day 5, and we don't see the third peak of mortality between day 5 and 10 from multiple organ failure anymore. And here is when the errors, or when the preventable or potentially preventable death happen. So you have number of errors there and phase of care. So the issue that led to preventable or potentially preventable death is listed at the bottom. So there were 2 cases, 1 potentially preventable, 1 preventable death. The issue was in the hospital. This is an esophageal intubation in the case that died, and in the other case was a tension pneumothorax that they put a needle and didn't decompress. The chest wall was very thick. Then you see that most of the stuff that when we mess up in the trauma bay. So you see the number in the trauma bay of the potentially preventable deaths are there. A couple cases in the operating room, 4 cases of potentially preventable death in the ICU, and then the bad stuff that happens upstairs. Now, in terms of the types of errors that we make, 90% are errors in judgment. We think it's something, but it's something else. And we don't act upon something that needs attention immediately. There is, a case here, a case there of nearing diagnosis. You look at something and you don't see what it is, or you interpret a CT the wrong way. And errors in technique are very, very rare here at UCSD. And these are the cases, at least 5 of them, not intubating a patient prior to transfer to the trauma center. This is a pre-hospital. This is the case that the guy was in respiratory distress. They thought it was a tension pneumothorax. They put the needle, didn't decompress, but didn't intubate. Well, if you don't secure the airway, all the bets are off. A attending anesthesiologist was not present for the induction in case of a lost airway. This was a sentinel case that some of you probably remember. Major surgery being done by one of the specialty groups in a trauma patient. Patient got in trouble. The resident couldn't intubate the patient in the operating room. The attending was not present, and there was a delay. Lack of recognition of hypovolemia and hypoxemia during rapid sequence intubation. So again, stuff that we need to be very attentive to particularly when emergency medicine is intubated in the trauma bay. Lack of trauma service consultation, a patient with subdural hematoma. This is interesting. We rarely miss a trauma patient in this hospital, but this guy came straight to the another service, transferred from an outside hospital, was a trauma patient. We were not consulted. Patient had a subdural. Nobody saw it. Patient died. And then inadequate use of narcotics in a patient with sleep apnea. I think some of you remember this. 30-some-year-old guy, again, my case. I remember this clearly. It was ATV season. I was on call on a Saturday afternoon. This guy came, had an ankle fracture. I talked to him, got a good history, healthy otherwise, never told me that he had sleep apnea. He was a little obese, but not huge, not a smoker, and went to the operating room. They fixed his ankle, got a little more narcotics than he should in the PACU, went to the 5 IMU, and the next morning he was dead. And that's about 8 years ago when the movement towards developing protocols for sleep apnea in the hospital started. I will never forget this case. But see, the kind of stuff that when we get in trouble, this is in the last 15 years, these are the reasons why we get in trouble. So again, that trimodal distribution went away. And why did it go away? It go away because we are very, very good as a team. It went away because we and you guys know what needs to be done for those patients. It's the aggressiveness in the trauma bay in terms of resuscitating, checking ABGs, making sure the base deficit is corrected, being very, very conscientious about those things, and then providing the excellent care in the ICU that made deaths from multiple organ failure and sepsis, at least in trauma patients, go away. You remember 15 years ago we had an ARDS patient every 3 days in the unit. Remember when we piloted the use of the prone bed for the company? There was a gigantic monster. Yeah, so at that time it was not uncommon to have 3-4 patients with ARDS, whiteout lungs, PCO2 of 100 on permissive hypercapnia. You all remember this. We don't see those folks anymore, right? We see ARDS in sepsis, but we don't see in trauma. So this is quite remarkable what has happened. So there are different features for non-preventable, preventable. There are many, many lessons that we can learn even when the number is very, very small. Attention, attention, attention is very important. Now we are interested in new outcomes. Not only that, but consistency and error reduction. I say this to me is as saying, put your actions where your mouth is, right? How often you do what you say you do. It doesn't help if you have protocols for everything, but you don't use them. So we gotta always look at the consistency of our protocols to decrease variability. And I want to show to you, again, I don't mean for you to read this, but we have a dashboard in trauma, and Juana and Madeline, who attend our division meetings, they get this every month. There's a bunch of stuff that we measure in quality. So these are trauma service utilization. There are no benchmarks for this, but you see the trend line there, the average from the prior year, and then month over month and year to date. And this is census, deaths, length of stay, ICU length of stay, etc. And then we have a section for trauma quality improvement program, the National Trauma Database, the caterpillar graph that I showed to you. And here is all the benchmarks, deaths, potentially preventable, and all the scores. Then we look at mechanisms of injury. We can have a pretty good idea, our penetrating rate going up, going down, blunt trauma, and in blunt trauma, what are the mechanisms? So if we find problems, we can refer to those numbers and then propose some changes. This is the severity of the injury in categories ISS from 0 to above 25, and mortality expectancy or survival expectancy by probability of survival, so expected over observed. Then we collect data we have our own report card. We are very interested in readmissions because we live in the times of healthcare reform, and if we have too many coming back to the hospital, we don't get paid. Return to the ICU, transfer to a higher level of care, return to the operating room, delays, errors, all the quality indicators are there, and we have this at our fingertip. And then we have the San Diego County trauma system measures. The county is interested in looking at pneumonias and DVT, and that's across all trauma centers. So we have to have this data immediately available, and then we can compare us to the county dashboard. And finally, we have the patient satisfaction data, because this is a big deal now, and unfortunately we don't do very well outside of the ICU. They hate us. All right, thanks for everything you do. You know, I want to show this as an opportunity to thank you, really, because none of these results could be possible without the work that you do. So thanks so much.